Good morning, everyone, and welcome to the VHHA-sponsored webinar on taking the first step to improving patient experience, engaging patient advisors. I would just like to review a few housekeeping items with you all before we get started, just in case you are new to this platform. Slides were sent out this morning to those that were registered. If you registered late, you can also access them in the handouts section of the GoToWebinar platform. This webinar is being recorded so it can be shared with others who are unable to attend live. We do ask that you please dial in using the telephone option if you are able. You'll be prompted to enter your audio PIN, and this will allow us to have a discussion at the conclusion of the webinar. At this time, all participants are muted and all panelists are unmuted. If you do have a question, we ask that you hold that question until the end of the webinar. You may ask that question in two different ways. One, you may raise your hand by going to the palm with the arrow on it in the GoToWebinar platform. Hopefully you can locate that now so we can be sure you can ask questions later. It is located on the left-hand side of the Grab tab. Please do this if you are dialed in with the telephone only. The second way you can ask a question is if you dialed in with either the computer's audio or the telephone, and you can ask a question by typing it into the questions platform, which is also located on the tab menu. We anticipate some good discussions on this topic, and I want to leave as much time as possible to ensure you can ask your questions to our guest speaker. Briefly, I would just like to review where we currently stand in our programming for 2017. In July, we will be releasing our Patient and Family Experience Improvement Guide. For those of you who do not know, this is going to be a best practice toolkit that will include case studies, and key strategies to be used to drive improvement within your facilities. This release will be accompanied by a Tableau dashboard trending hospital-compared data over time. I suspect this will save your hospital's time and be a good resource in understanding where you stand in comparison to your peers and with your historical performance. And of course, all of this work is meant to initiate collaboration between hospitals, share learnings, and reference materials to help with improvement. On the right, you'll see our future programming. We will have programming in November and December. We're in the process of scheduling those now. Registration links for our next webinar will be sent out next month, and that webinar will be on the improvement guide and our data Tableau dashboard that we'll be releasing. Today, it's my pleasure to introduce Dr. Tom Workman. Dr. Workman is the principal researcher at the American Institutes for Research. There, he focuses on health policy and healthcare quality improvement through patient and family engagement. He has worked on a variety of projects related to involving stakeholders, including patients and caregivers, in healthcare research, service, and policy decisions. Dr. Workman has more than 15 years of experience in coordinating, facilitating, and evaluating stakeholder engagement in a variety of settings for health policy and program implementation. At AIR, he has led or contributed to multiple projects for CMS, the Patient-Centered Outcomes Research Institute, and the Agency for Healthcare Research and Quality. He serves as an advisor to AIR's Center for Patient and Consumer Engagement. Tom holds a PhD in Communication Studies with an emphasis in health from the University of Nebraska-Lincoln and works out of AIR's Chapel Hill, North Carolina offices. So, without further ado, Dr. Tom Workman. Tom, take it away.
Thanks so much, Mike, and welcome everybody. Good morning to you, and grateful for the opportunity to spend some time with you this morning on something very important, which is engaging patient advisors. And we really are going to focus on the early steps here, and I'll talk about some of the broader goals of PFE this morning, and then move us towards some of these first steps, which are absolutely critical and great ways to begin your sort of journey with engaging patients as partners in improving your hospitals. Really, patient advisors are the greatest gift to a hospital, and though many times it feels like our upper leadership may be a little resistant or concerned about this sort of change of paradigm in involving patients as partners, most hospitals who have engaged this way found that this is actually one of the best gifts they've ever received, because they get a really first-hand view of what the patient experience is and really an expert opinion about how to fix problems, how to make things better, how to make improvements, how to make things safer, and how to create ultimately a better hospital environment. So we'll focus throughout all of that. I want to start with CMS's definition of patient and family engagement, though, just to keep us all on the exact same page. We define patient and family engagement for the Partnership for Patients specifically as persons, families, their representatives, and health professionals, that may be clinicians, staff, or hospital leaders, working in active partnership at various levels: direct, point of care, organizational design and policy and procedure, organizational governance and community policymaking across the healthcare system, and in collaboration with communities to improve health, healthcare, and health equity. Now, let's take this apart a little bit and talk about some of the core principles that represents. First of all, one thing you'll hear very clearly is that patient and family engagement happens at multiple levels. We often think about patient experience just around direct care or the point of care. And in fact, however, that point of care is influenced by many other levels of the hospital. Certainly, what happens in the quality of point of care is controlled by the policies and procedures of our hospital. It might even be controlled by the philosophy and mission of our hospital in some way. So having patients engaged as partners at each one of these levels becomes critical. Second, families defined broadly and by the individual. And we sort of understand today particularly that a patient can determine what family ultimately means, as opposed to a court of law or a legal document. Many people engage parts of their family, literally parts of their family, while others engage friends or associates or pastors or any variety of people. The goal is always that we move towards an active partnership. In fact, this is somewhat of our mantra, and I encourage it to be yours, that when we think about engaging patients, we think constantly about the word partnership. And I have to tell you, that's a bit of change from what we're used to. We're used to thinking about patients more from a customer position. And so we tend to think about patients as satisfied customers or patients as happy informants, as opposed to thinking about them as actual partners. Partnership is unique because it has shared responsibility. And what we're finding is that more shared responsibility that we give to our patients, the better the outcomes. Now, patient and family engagement requires both individual and system behavior change. Again, we oftentimes think that this is simply a matter of communication between the staff or the clinician and the patient, that good patient experience is communication-based. Now, it certainly is. There's no denying that communication and effective communication is critical in creating this kind of partnership. We only partner with people that we think we can communicate with. On the other hand, or people who especially who listen to us. On the other hand, there are real system behaviors that have to change, perhaps everything from our visiting hours for involvement of family to the way in which we approach any one of our procedures, which may in fact be antithetical to good engagement while in the hospital. And finally, this is really about identifying and responding to patient and family identified needs and desired outcomes. These are often different than our own because ours are based upon our organization or our institution, and patients may be very much about their individual personal lives. Between those two things, though, is a wonderful connection, and that's what we're after when we work on patient and family engagement. Let's see if I can get, there we go. So let's talk about those benefits very quickly before we move. Oh, nope, let me start with the poll. Sorry about that. And I'd like to get a sense from you about your biggest barriers to having patient and family advisors in your hospital. And you'll see a variety of, on the screen, different possible answers. You may have something other. Pick whatever feels closest to you. And let's take a look at your responses. I always feel like I should sing the Jeopardy song at this point, but I won't. And Mike, our webinar host, will give us some idea of what we see for responses in just a moment. One challenge we hear, for example, is that people aren't able to find enough patient advisors, or they don't have internal leadership who can run patient and family advisor councils, or even individual patient and family advisor programs. There's concern sometimes about transparency. We're afraid to share hospital information, and there's concerns about confidentiality that may be HIPAA related. Any of these connecting with you?
All right, Tom, it looks like we have 44% are saying that we are unable to find enough. 19% we do not have internal leadership. 31% concerns about transparency, and then 6% concerns about confidentiality.
Great, thank you. So interesting, because we're going to constantly look back and forth between these two concepts here. One is hospital buy-in, and this is going to be very important as an initial step in creating this kind of patient advisor role at your hospital, because there is a constant sort of informing and educating that has to happen across hospital leadership, and lots of resources to help you do that, by the way, including us, the patient and family engagement contractor for CMS, but lots and lots of resources to sort of help hospital administrators understand or overcome some of their concerns in this. But then we also have these very practical issues, like who's going to do it and how are they going to do it and what way are they going to do it. And so certainly these are elements that we want to address and try to think about as we go forward. Thank you for your responses. So towards that selling, let's talk a little bit about some of the benefits of person and family engagement. And it's really important to recognize that we do see very specific outcomes that emerge because of patient and family advisors in a hospital setting. We really have been able to measure that. Hospitals have seen, and hospital systems have actually seen results of much quicker improvement in safety and quality measures when they've had active patient and family engagements. And we've also seen far greater effectiveness around patient satisfaction and patient experience itself. Those scores have gone significantly higher in hospitals where this exists. And finally, we wind up creating something that is becoming increasingly important for the bottom line of a hospital, increasingly connected to reimbursement particularly, and that's patient-centered systems of care. We're certainly seeing additional models going forward. There is ongoing movement towards this, and critical for us to continue to think of how we create this in our hospital. There's a clear relationship between the patient and family engagement that we do in our hospital and the patient system created centered systems of care. These are just three arguments that can begin with your C-suite, and certainly, again, let us know if you need additional materials because they exist for you. Let's talk for a second. I'm sorry, my slide switcher is being overactive. Let's talk just for a second about CMS's vision, just so, again, we're all on the same page. Hospitals and other healthcare providers achieving quality and safety goals by fully engaging patients and their families, determining what matters most to them in every situation, and partnering with them to make improvements to all aspects of care. The one thing I want to have you see in this vision, and encourage you to adopt this vision at your own hospital, that as you take a look at this vision, you'll see a couple things. First of all, patient engagement is never for its own means. In other words, we don't engage patients because when we do that, we have engaged patients. We engage patients because they help us achieve quality and safety goals. They really become key contributors to the goals that we hold about quality and safety. They can improve all aspects of care as partners. Now, the way that we do that, though, is by determining what matters most to them. Their expertise certainly is their preference. Their expertise is their experience. And so one of the challenges we have is we often try to hold patient advisors to a different set of standards than what we've actually brought them in for. The vision here is that we use their expertise and combine it with our own, and that together that partnership is most successful. We may understand the medical issues related to CAUTI, for example, but our patients understand what it is in having a catheter that makes them feel potentially vulnerable or make them concerned and don't know when to speak up and ask a question, or even to know how to become a partner to help reduce quality infections, either as the patient or, more importantly, as an advisor who can help the hospital in trying to lower the cases around catheter infection. And so here's a great example of ways in which this vision becomes realized. And this is the vision that we're ultimately after. So as we go forward, I want to again remind you about these different levels and let you know that CMS is thinking about 3 specific levels in their 5 PFE metrics, as they call them. This is the measurement criteria that every hospital in the Partnership for Patient is asked to consider and asked to adopt. And there's implementation really in these 5 areas. At the point of care, planning a checklist with patient and family, having shift change huddles or bedside reporting. Again, those are direct engagement with patients at the point of care, either again at the point of admission, throughout the point of discharge, or in PFE2 at the bedside whenever a nurse shift change occurs or whenever a clinician is providing a report. At the policy or protocol level, we have having an individual PFE person who is proactively responsible for the PFE activity, the person who can be accountable to the hospital, or as I like to think about it, just known by the hospital as the coordinator. Now, this doesn't have to be a full-time position, and it certainly doesn't have to be a full office title and all those sorts of things, but as you've mentioned, that leadership is really critical. And I think this may be one of the most important first steps that are taken as we move forward, and that is, who can I pick at my hospital who can really sort of oversee PFE, who can work directly with our administration and certainly work with a variety of staff to be the coordinator for PFE, to be the knowledge holder, to be the person who can assist. This is usually the person who will wind up running the PFAC, for example, but this is really a critical first position. Who can take this over? And again, it may be a set of people, it may be a series of people, but someone at the hospital who has that. Some hospitals use patients themselves to do that, a patient advisor position that they pay either part-time or full-time, or even volunteer. Others wind up doing a nurse staff or some other hospital staff, and some use a combination of those two. Obviously, PFE4 is this idea about having an active PFE committee or an advocate, a patient advocate specifically on a PFE, any hospital safety or quality committee whatsoever. Having a full committee of patients and family members, oftentimes what we call a PFAC, a Patient Family Advisor Committee, oftentimes is actually a mix of patients, family members, as well as hospital staff, clinicians, etc., because it's a dialogue between them that becomes most important. Again, they become an advisory group who actually consider different issues the hospital is dealing with. And again, sometimes we think these are issues just about the color of the walls or the signage, and those are important things. But these committees across the country have been incredibly effective doing all kinds of other things, like, for example, addressing the falls that are happening within the hospital. There's a PFAC in a hospital specifically in Illinois that has seen dramatic decreases in their falls just because they put their PFAC over it. They said, as a patient or family member, what are your thoughts about what we could do to help reduce falls? They listened, they modified, they worked together, and they've seen a great drop in that issue at their hospital. Now, having an entire committee of patients and family members along with staff and clinicians may feel incredibly overwhelming at this point. You may really be at the very first starting place. And so one of the things that also counts here, and I think it's an important first step, is to find individual patients and family advisors who can serve on your current hospital committees and can lend that perspective from a patient or a caregiver on that committee. And hospital safety and quality committees tend to be the most popular places to put this in, but we really encourage perhaps any variety of committees that might be appropriate, or places where you could really see the perspective and the addition for the patient and family member. And then finally, at the highest level of hospital governance, CMS encourages everyone to have a patient representative on their board of trustees for the hospital, someone who is a trustee and represents the patient or family physician specifically on the board itself. Now, there are boards, and there are hospitals certainly that are unable to change the nature of their boards because it's written into law or statute or some form of regulation. And there are many alternatives for this. The point of this and the intention for this is that at our highest level of hospital administration, we want to make sure that there is, again, a patient perspective involved. And so PFE 5, as we call it, is particularly important to get us towards that goal. So let's take a second and do one other poll if we can, and get a sense about these 5, which one feels the most daunting to you? Which one feels the most difficult for you to get your hospital to implement? Again, just take a second and select one. You might want to select all 5, but just select one, please. And again, really think about what's the hardest for us right now, when I just can't imagine we're able to get to yet. Some of these clearly are harder than others, and I'll tell you right now that across the nation, I think most hospitals struggle with, number 1, planning a checklist for scheduled admissions, and number 5, having a patient or family on the hospital governing or leadership board, because those require involvement from others. Again, many times our patient and family leader, number 3, is from a nursing staff or from a clinical staff or from a patient themselves, and may struggle with the access to get to some of these other areas. One thing I want to let you know, and we'll talk about this at the end of the webinar, we have individual webinars available to you, your hospital, anyone you wish, that you simply can download, that have all the audio and all the slide sets and everything just set for you to watch on each one of these metrics if you want to learn more about them. Each one is there, as well as described in the roadmap.
All right, Tom, it looks like we have here 8% saying planning checklist for scheduled admissions, 23% for shift change huddles, bedside reporting, 22% patient family engagement leader or functional area, 19% patient family advisory council, and 30% patient and family on hospital governing and or leadership board.
Yeah, thank you so much, and I agree that's usually the most difficult. But I also appreciate that for your hospital and your setting, any one of these might be a greater challenge than any other one. And so let's start again at the easiest, simplest steps. And I've said to you that one thing to do is to look internally into your hospital and see who your champions might be. Who gets it, or who is willing to talk about getting it in the importance of patient and family engagement? Who might have some time to start to devote to coordination, or how might we begin to set up a system where there's someone that we turn to or go to, even in very basic rudimentary ways, maybe only for 10% time, who can help us coordinate PFE across the hospital. What we find is oftentimes this person kind of naturally emerges. They're already starting to blossom at your hospital. Chances are it might even be you because you're on this webinar, and we just need to formalize that a bit, and that's PFE metric 3. And so that's an important starting place, because I think you'll find the rest much easier once you get to that. Let's go to our second poll and really start to dig into this now. How do I engage these patient and family advisors? And so I'm going to ask you another biggest challenge question, and that's your biggest challenge with engaging patient and family advisors specifically. Many of you answered this was your greatest challenge, so let's get specific about what the challenge is. Just take a second here. Is it getting buy-in or support from hospital administrators to even have patient and family advisors in a formal role? Is it getting buy-in from clinical staff to want to work with patient and family advisors in committees or other hospital functions? Is it having the resources that you need to implement the PFE metrics? which might be time or costs, financial costs, etc. Is it understanding what we do for each metric, which is kind of get what exactly we're supposed to do and how we're supposed to do it? And is it finding patient advisors who we think are willing to be engaged, finding the actual people who we think can be engaged?
All right, it looks like we have 0% for getting buy-in from hospital administrators,
Great.
10% from getting buy-in from clinical staff, 52% for having sufficient resources to implement PFE metrics, 14% for understanding what it is we are supposed to do for each metric, and 27% for finding patient advisors who are willing to be engaged.
Excellent. Thank you so much. So let's talk for a second. Again, part of the purpose of these goals is so I can be as specific as I can to your expressed needs, and so that we can answer as many questions as we can. My next slide is going to talk about finding those patient advisors, but I want to spend a minute giving your responses on the sufficient resources to implement PFE metrics. And this is a challenge, certainly, for many, many hospitals, particularly rural hospitals or small community hospitals who don't have the same resources as major systems. Now, one of the pieces of good news is that there's been an awful lot around the training and physical resources that are needed to do patient and family engagement or to find patient and family advisors that you don't have to invest in. They're all provided for you free as part of being in the Partnership for Patient programs, being a part of the VHHA and VHAA, being part of the larger American Hospital Association's HRET, having CMS's involvement. There are lots of things that exist for you already in training resources, in documents that you can borrow, in templates you can use. That's the really good news, and I'll talk about where all those resources live for you. And certainly you're about to get another one in July from Virginia itself. And so those resources are something you don't have to worry about. The big resource, of course, is personnel. And the question about how on earth we get people to have time to deal with this, especially if our staff is already feeling overworked at the time, how do we start to add to this? And this is a very realistic question, and one that may take some long-term planning for us to think about. How might we use, for example, our hospital foundation or other fundraising or volunteer services to begin this process? How can we share responsibilities? Again, PFE3 doesn't have to be accomplished by just one person. You might have a group of people who can each donate maybe 5% of their time during the week to coordinate some aspect about patient and family engagement, or to run the Patient and Family Advisory Committee, or simply work with the patient and family advisors who are sitting on your committee. It may not require a full-time position of someone in patient and experience, and many, many hospitals begin this journey through volunteers. And luckily, hospitals are one of the places that does attract a wide range of volunteers. So there are ways to begin in this process to collect some of those resources. I'll tell you what, one of the resource expenses beyond staff tends to be things like food, etc. And ultimately, we want to get to a point of compensation, right? So we want our patient and family advisors to be seen beyond volunteers and to actually become a contributing part that get paid for their contributions. Some hospitals have begun with easy things, making sure they don't have to pay for their parking and making sure that they have a place to park when they come for a meeting, or they have a meeting in a place more convenient to them. These little things can take some resources, but again, oftentimes become volunteered in really wonderful ways. And so as we think about how to budget for patient and family engagement, one of the questions that many of our hospitals have, again, we have some resources available for you to think about how you do this on a shoestring budget and where you might find some additional resources. So again, I'll refer you to that in just a little bit as we close out. let's talk about how we get started finding these patients. And I want to suggest to you again that many of your volunteer programs are a really good way to begin for a couple reasons. One, you already have folks who are showing some commitment to the hospital and clearly want to be connected with the hospital. Some hospitals begin in a really simple way by starting to have volunteers spend lunchtime together, or even a coffee break, and just come sit in the cafeteria for 15 minutes, a group of the volunteers, or take 15 minutes out of a volunteer meeting, if one is held at your hospital, and start to just talk about what do you see here that is helpful, or even start to talk about very specific things. We're trying to address falls in this hospital. What are some of your thoughts about that? And begin this process of helping volunteers recognize that more than time is something that they can volunteer, that their opinion, that their experience is something else that they can volunteer, and is very, very helpful for volunteering. Part of this is simply to move patients from patients to advisors. And there's a very simple way that that happens, and you'll be almost angry with me for how simple it is, but really the research says the best thing to do is invite them. In other words, we have to simply ask those people who are currently patients to share their opinion. Are you interested in telling us what you think? And there are very few patients and family members who are going to say no to that question. So you might want to have some roundtables or focus groups with patients who have recently been discharged. You might want to and I recommend that you don't just look at patients who have had difficulty with the hospital. Some hospitals have tried to go to those who have complained to their patient experience office or to their community relations office about their treatment at the hospital, thinking that they could transform that into some helpful advice. That is sometimes true and sometimes not true. And so I think we have to think about that carefully, but I would have a nice blend of people who have had wonderful experiences, who have had all kinds of experiences, or who are literally from the community, regardless of their experiences, but know the hospital as part of their community and have thoughts and perspectives from that direction as well. Many of our hospitals, it's hard for anyone in the community to not have some connection to the hospital itself. And so starting to invite our discharged patients, just sending, as many people send satisfaction surveys and experience surveys out, sending a very simple email or a mail letter saying we're having a group coming up next Saturday or Saturday morning or Friday afternoon or Friday at lunch, and we just want to spend some time hearing about experiences and talking about your opinions on things, gathering your advice. And again, that invitation oftentimes yields some beginning interest that can be culminated into a more long-term relationship, even to the point when we name someone officially a patient advisor. Now, again, I want to be very clear that that formal role of patient advisor isn't necessary in order to have really active patient engagement or even to have a patient and family advisory committee. Some hospitals do a very formal role saying you are this year's patient and family advisors. They might say to 10 or 12 people or people who they have asked to be on the patient and family advisory committee. Others will simply say we have a patient and family advisory committee without those titles, and so either one of those might be helpful. I always recommend looking at community organizations from your area, whether that's Kiwanis or Rotary Club or very specific cultural organizations or any number of community groups. These are wonderful places to start to make partnerships and connections. Simply offering someone from the hospital to come and speak on something like infection rates at the hospital and how we control infections or how we do any number of things at the hospital, or simply understanding your hospital and your community hospital and the issues that surround keeping a hospital viable and healthy in a community. It's often welcome to one of these groups and a great place to invite groups of people who are already involved somewhat in some active citizenship to be a part of that. I want to say specifically a word about cultural organizations, and if you're very rural, this may be a little bit more challenging for you, but some of you live in areas where there are particular clusters of populations, whether that's Hispanic, whether that's Asian of some form, or any other type of immigrant community. And again, we're tending to find these as settling within a set of communities. Oftentimes, these communities have got their own organizational structure, and it might be everything from a church structure, such as a Vietnamese church, or it might be something more aligned to a general association of Vietnamese citizens or Hispanic citizens, or those sorts of things. These are great places, again, to partner with, especially when you want to make sure that there's a connection to these groups as patient advisors, and so that's also going to be helpful. I never undermine personal contacts. I think that especially your nursing staff and your clinical staff are constantly running into patients that they think, wow, you would be great to have as an advisor, and the sort of keeping, even while in the hospital, again, depending on obviously the patient's condition, but saying, you know, I'd love to have you join us once you're healthier, once you're all healed up, and being a part of, or stabilized or whatever, and being a part of our advisor group. You just seem like someone who would be great at that. And again, it's amazing what the invitation alone will do. And finally, we do suggest you think about your current or recurrent patients and their families. And I will say again, a whole committee of these folks is perhaps not as helpful because they have unique needs from a single visitor. The person who went to the hospital once in 10 years is extremely valuable. One of the things that they're most valuable for is this perspective that my role as a patient is very separate from the rest of my life. And that alone has been incredibly helpful for hospitals to think about patient-centeredness as not just centered in medicine, because medicine is not centered in the patient's life. But it is also helpful to talk to current and recurrent patients and their families. Our own patient and family contract team, the folks here who help promote this across the country for CMS, has a patient and family advisor committee, and has on that committee someone who has a daughter with a chronic condition that he has interacted with his hospital so much he thinks they're going to name a wing after him soon. And the truth is that his perspective is really unique and interesting, but not the same as the perspective of other advisors. So I do think that there's a role for someone like this. And again, chances are there's a stronger personal relationship with clinical staff already that can help move this forward and make that happen. So let's, sorry, still having a, there we go. Let's take one example from Carilion Clinic there. You have a really interesting example here where, again, using volunteers as a start of this, they actually recruited them to participate on their hospital's Quality and Patient Safety Committee. Not everyone, and not as an entirely patient committee, they just asked some volunteers if they'd like to serve on this one committee. The committee meets every month. And certainly what they found was that they did get a different perspective from a non-employee, and that they heard very different things in that committee that they wouldn't have heard if they didn't include that volunteer. They discussed about safety issues and trends. They're able to help that clinic understand the view of the patient or the family or the visitor. And the president of the volunteer organization gives an annual report at their hospital board meeting and talked at their last board meeting specifically about the volunteer role on the Quality and Patient Safety Committee. At Carilion Clinic, it's starting to work very well, and it all started with volunteers. A great first way. Again, had many of the same concerns and challenges that you have about getting started, and was able to sort of begin movement in this direction. So I want to encourage you that this is more than possible, and you may find that volunteers are a good way to start as well, from your volunteer group, in other words. Sorry, just trying to get my next slide up. There we go. I also want to share something that I adore and that we've shared across the country from Minnesota. The Minnesota Hospital Association and all the hospitals involved in Minnesota have this very simple mantra, and it's called Include Always. And they have postcards of this, they have buttons of this, they have it on a lot of their documents. They have it sort of spread across in their grand rounds for clinicians. And it's just a very simple way to start to raise the mindset. Remember, we've talked that one of our first steps might be to try and help my hospital, and especially our clinicians who aren't used to a patient partner role. That's a very different perspective for many clinicians. And to start to think about how that might happen, in what ways we might do that. How do I keep this in everyone's minds? Well, one of the ways that we begin is, again, sort of starting with something very simple and basic. And Minnesota found it in the phrase, include always. Now, oftentimes they will use at grand rounds or staff meetings or any number of events, ways to explain what that means for them. And it means something at all three levels at the hospital. It means include the voice, the perspective, the consideration, include the actual human being always whenever we're engaged in clinical practice, whenever we're engaged in care, whenever we're engaged in policy making or procedure setting, whenever we're involved in major decisions. And that just sort of became, gosh, did we include the patient voice in this? That question started to raise into people's minds and help them start to think of the ways, many of which I've shared with you today in the webinar, to begin to do that. And so there is wonderful opportunities to sort of begin here. The other thing this did that I have to tell you, because it seems important for many of your hospitals, is it really started to then show a commitment on the part of the hospital that really picked up a lot of energy from patients. In other words, patients love this in Minnesota. Patients respond to it. They feel like it says the hospital when they see these buttons and they see posters and they see things around the hospital that say this. And when they hear about what it means, they actually feel differently about the hospital. They feel greater trust for the hospital. They feel a greater sense of reliability. And so, again, a really important issue. Now, I'm going to recommend a second step that goes with this. As you start to help people think about including always, that you also start to collect the stories of when people feel included and the way they felt included and what happened as a result of their being included. Those are critical stories, again, to move forward up to your administration and continue the commitment so that more and more resources can be placed on this. This is why it's very important this gets in front of a board, because oftentimes your board controls those resources and may work to find resources if they see this is an important pathway towards improving the quality, safety, and I would add success of the hospital itself. So I want to talk for a second about our roadmap. And again, you see over under handouts the PFE roadmap and addendum that is available for you to download at any time. And we encourage you to use it. This is literally a roadmap. I'm going to talk about what that means when I say it's a roadmap in just a second. But let's start with the 6 strategies in the roadmap. How do I do this? Let's say I want to create a PFAC. What do I do to get started? We're going to recommend there are 6 things you should think about and do in order to accomplish the goal of having a patient and family advisory committee, or even having patient and family advisors serve on hospital committees. The first is what we call organizational partnership, and you heard me talk about it earlier. It's when we actually find partnerships with different community groups where we start to make connections between patients and the hospital organization, and we build some of those just general partnerships. And then we can utilize those as we start to create a more formal program, like a patient advisor program or a PFAC. Those really begin by just focusing on organizational partnerships. So one task someone or a committee of someone at the hospital may do is sort of, let's just spend 20 minutes brainstorming who in our community we should be partnering with to find patient advisors. Well, we've got a thriving Rotary Club in our community. Great. Let's see if we can't get to a Rotary Club meeting, or maybe someone at the hospital is already on the Rotary Club, and that's an even better connection. My guess is someone probably is, or on Kiwanis or any number one of these. The second step is patient and family engagement. I cannot engage patients without helping them be engaged. One of the challenges that we see often with patients is that their experience, again, if it was traumatic, regardless of the hospital's role, if it was traumatic, then chances are a patient may need time and distance before they're able to sort of jump into an advisory role. Don't think that patients who have had tragedies that may have happened from medical error are unwilling to serve. Many are, but they may need to separate their own story from the larger working towards a solution. Their story has a valuable place, and what we find in that transition is to let them have that story and tell that story and use that story, and then help them move from that story to how they can solve it. The story for the patient changes. The story once was, perhaps I lost a loved one due to an infection that happened at the hospital. The story becomes, I lost a loved one because of an infection in the hospital, but I've helped save hundreds of people from that infection because I joined with the hospital to come up with ideas to reduce that problem. That's a new and different story that, again, we have to prepare patient and family members for. But it also means that, and I'm going to jump over to transparency and accountability on the bottom of the right column, we have to make sure patients know what they're talking about and they're aware of how hospitals operate and what they do and the way in which they do it. Certainly, we have to help clinicians, staff, and leadership be prepared as well. How do I talk to and work with a patient? What do I do? What should I be thinking about when we run any kind of committee with a patient advisor? What changes? What's different? How much do I have to translate? What do I do? Sometimes we see that we have some redesign in our system itself, and so we have to add that step in. And certainly, we want to measure. And so we want to think about what we're going to do in creating this program around measurement so that we can see the outcomes and use the outcomes to promote additional patient experience opportunities. All 6 of these, here's the good news, all 6 of these strategies have lots and lots and lots of resources available to them. And so again, you'll see in the roadmap some opportunities to find those resources. And VHHA will also help you find a variety of resources that tell you exactly how to do these 6 things. What I want you to think about is, what order should they be? What's the road actually look like for me? Where do I start? And I'm going to suggest you start with the partnerships. Just as we talked about, let's start with developing 2 or 3 or 4 or 5 relationships with patients or family members in my community that have experience with the hospital, particularly both positive and negative, who might want to shift from a patient to an advisor. Again, doesn't have to be formal, but let's just start that partnership. And again, it could be as simple as, let me invite a few people to lunch to talk through their thoughts and opinions and experiences. It might be as simple as inviting someone to be a part of a committee. We want to prepare those patients and prepare staff. I think those are the first 3 most critical strategy steps. And don't forget those other 3, which may really help as we try to create the system itself. And so thinking about your order depends on what's happening in your hospital and what your hospital has as its greatest need to move something like this forward. The roadmap will go through these strategies in more detail and can tell you a little bit more about how they can be applied to accomplish each one of the PFE metrics we talked about earlier. So let's think for a second about how we prepare patients to become advisors. How can we help them learn the language? Because there is medical language, and that does have to be learned, and it's a little bit different. Again, you've heard me talk about helping the patient transform their story from telling their story and the difficulties they might have experienced, either because of the illness or because of the treatment or any coordination of things, but then helping them inform the patient's perspective with this bigger picture about a hospital trying to improve itself, about medicine and medical care, trying to create safer approaches for all individuals. We forget that infection control, for example, is a phenomenon that is worldwide. It's not necessarily connected just to one hospital. And we're constantly learning new ways to battle it. And so bringing a patient in and saying, yep, we are fighting bugs constantly, and we'd love your help. How do we transform those stories to that larger goals? How do we help them share responsibility? And sometimes it's hard for a patient. They're used to being consumer as well, so they don't quite get that, no, we really need you to read, and we really need you to be prepared for our meetings. And again, how can we help communicate impact? How can we help patients tell us what happened by their being involved as an advisor? So important as we continue to build buy-in. Now, on the clinician side, lots of things to perhaps prepare the clinician or administrator for. And that's, again, this new view of patient expertise. We don't expect the patient ever to be an expert in medicine and technology, in any of those things. You may luck out and have a patient who's also an engineer. That happens a lot, but we're not bringing you here because you're an engineer. We're bringing you here because you're a patient. And so to really help a clinician understand what's a patient expertise and what can they do, we need their help in understanding there's a specific role that we want to redefine from customer perhaps to advisor. And we want to connect with plain language and show them how to use plain language to describe many of the things that they use lots of jargon for. We want to teach clinicians how to invite and how to listen. And this might be new skills for them. Remember, our greatest and most brilliant clinicians aren't given lots of training in communication skills. We may have to help them in some of those areas, some very simple tips. And how do we disconnect engagement from patient satisfaction? They may be used to thinking about that paradigm. And certainly how we help them build some trust with patients through some transparency. And again, careful transparency. We never want to violate HIPAA, but lots of ways to expose a patient to the inside of a hospital setting without ever violating HIPAA whatsoever, or without ever really putting much of the hospital's information at risk. So having said all that, hopefully I've given you a few ideas about how you can get started in this, and I want to open up and answer any questions you might have. So I'm going to turn back to Mike and let him sort of moderate that, but certainly please let me try to answer anything possible for you. For me, the goal here is to make this as practical for you as possible, and so please don't hesitate.
Thank you so much, Tom. That was fantastic information. Again, guys, this is your time to ask any questions to him. You can do so by either raising your hand, and I'll unmute your line, or you may type your question into the questions panel, and I will read the question out to Tom. Okay, looks like we have one question here. Our community has people from many different ethnicities and races. How can we ensure our PFACs reflects this?
Yeah, thank you. That's a great question, and we got to talk about it a little bit. I'd love to talk about it just a few seconds more. First of all, let me say, it's really important, and you'll find that we also have, CMS is very interested in the concept of equity. There are clear health disparities, and I think one of the challenges of family engagement and patient engagement is this issue of ethnicity and language particularly, right? So I have someone who is clearly non-American and unable to, and by non-American I mean immigrant, someone who has come over, but who doesn't have English as a primary language and who may not understand many of our customs and many of our processes, and might even have a very different mindset about those processes. Easy to sort of ignore this person in patient shift, in nurse shift change, bedside, for example, or skip over this person thinking about them being an advisor, because it's hard to imagine how they could possibly do that. And yet these people might be most important because they're in your community, because they're a part of someone that you will, a population you will care for. And so we want to make sure that we have ways to help them become advisors. And lots of those resources, again, are sometimes made available to us in volunteer ways that don't necessarily cost us great resources. Even translators through family members, through community organizations are very commonly provided with very minimal or no cost. And certainly we have a little bit more work to do sometimes with someone who has a different cultural perspective. But that one-on-one interview perhaps, where we start to understand, and if not that one patient who doesn't quite understand, but someone representing that person's ethnicity might be able to be someone you can sit and talk to get a better sense about this. The Hmong community, for example, has done phenomenal work in sections of the country where they've populated in providing literature for doctors, for lawyers, for police, for a variety of different civil servants to help them understand the Hmong culture and how a Hmong individual might react and how best to begin that interaction, while also working, by the way, to help acclimatize the Hmong people towards American culture. This isn't all about adapting in the hospital, but understanding how this might get affected. You have certainly people from ethnicities who might not speak up as much and need more than a simple invitation, and others who might need less. And so it is important that we try to find ways to connect to those ethnic groups that we know we're going to be serving because of our community makeup.
Thank you, Tom. Thank you. We do have another question here. How do we avoid using PFACs solely as a soundboard or focus group? We want our PFACs to produce outcomes and results, or outcomes and projects. It is difficult to identify possible project opportunities.
Yeah, thank you, and hooray for that question, and hooray for that thought, because it is easier to think about this as a consumer advisory board, and it's not going to yield much for you. It's really not going to help as much as you'd like. What we find is that we think that's easier, that it'll be easier to get patients to just share their opinions like a focus group. But what we're finding across the country is patients do want to be actively involved in projects. And so looking around your hospital at the things that other committees are doing, or again, combining with what other committees are doing, what is your hospital safety and quality committee working on right now? And what aspect of them could use being informed by a patient and family advisory committee or by that patient and family advisor? So are really thinking about what are some of the key issues in our hospitals right now, what are our goals? And those are all kinds of goals. Asking about the patient perspective, what does this reflect in the patient experience? I'll tell you the hardest that I've ever encountered was trying to get patients to give advice about payment model structures and changes. And this is really hard for a patient, because most patients aren't aware of exactly how everything gets paid and prices and pricing structures and all those sorts of things. So as we talk about payment models, this is really hard. Well, it turns out we had patient advisors who had many ideas about this, who had lots of thoughts about how a payment structure might really benefit their own care. And we were able to see across things that most people didn't think patients could see, such as the impact of a payment model on their accessibility to certain things and their accessibility to treatments, et cetera. And so there are lots and lots of topics that, honestly, our first step is to get over our own possible paradigm that says, oh, no, that couldn't be something a patient and family group could do. I am amazed daily at what a patient and family advisory committee can do, daily, and hear these wonderful stories. But I'd start with the agenda on your patient quality and safety. There are 10 measures in the 10 standardized measures in the Partnership for Patients that are a great place to begin.
Great. Thank you, Tom. And we have time for one more question here. Let's see. So, how do you combat attitudinal barriers in leadership to engaging with patients as advisors? For example, fears that will compromise confidentiality or fears that their suggestions will be unreasonable.
Correct. And let's take unreasonable objections. And so I want to say let me start generally. Let me say two things. One, it's really okay that people have those attitudes. I think the first thing to do is not fight them, or not certainly identify them as problematic, because it is the model we have followed for a very, very, very long time. And so I think it's really important that we sort of get over what is good or bad or right or wrong about all of this and say, how might we think differently about it? And what aspects are we learning now about patient contributions that we didn't know 10 years ago or 5 years ago even? And so beginning with sort of understanding what is possible and what are safeguards. I think worries become really good checklists And so we're thinking about, so how might we inform confidentiality? What might we have to do? How do we help a patient self-identify in ways that protects their confidentiality, or expose them to information about other patients that protects those patients' confidentiality? It may help us sort of, and I, again, would ask the patients to help with that because they have some ideas about that as well. And so important that they actually help solve that problem and work with you to solve that problem. The other issues, though, are very common and often just is a paradigm change, and we have to slowly build the argument for. Luckily, you have many other hospitals across the country who have been building that argument and have been showing places where patients are making an improvement for the hospital couldn't have seen before. Ultimately, our administration is most interested in success. And when we can tie patients to success, that's our best approach in our argumentation. Again, I don't want to shove it down your throat on a moral position. There's a business case here. And important that we talk from the business case. And one of those matters, by the way, again, we have some resources on this, is that it actually has improved the enjoyment of work for clinicians and clinical staff. This is critical for hospitals who are losing staff regularly. If I could make work more joyful through patient engagement, there's one of the best reasons to start to adopt.
Fantastic. Thank you very much, Tom. We are out of time. If you have additional questions to Tom or myself, his contact information is on the next slide. You guys have my contact information from all of my communications. This is an increasing trend in healthcare, and I suspect as more and more data comes out showing that this is an excellent way to improve quality, safety, and patient experience, the more you guys will be implementing it at your hospitals. And so this is a topic that we're definitely going to touch base on later this year and as we move forward with programming next year as well. So thank you very much, everyone, for being on this webinar. Thank you very much, Tom, and we will see you all very shortly. Take care.